Hi, everybody. Good afternoon, and welcome to our Hot Topics Webcast Series, Part 3, Mycobacterium Disease in Humans. I will be posting the presentation handouts to the chat box shortly, but so that we can go ahead and get started, Dr. LoBue, can you hear me?
Yes, I can. Can you hear me?
Yes, perfect. Okay. So I would like to introduce Dr. Philip LoBue, our speaker for today. Dr. LoBue is the director of the Division of Tuberculosis Elimination in CDC's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. Dr. LoBue is a fellow in the American College of Physicians and American College of Chest Physicians. He has authored or co-authored more than 80 publications, including peer-reviewed journal articles, book chapters, and Morbidity and Mortality Weekly report articles. He has chaired on or served on more than 10 guidelines and recommendations committees and panels for multiple organizations, including CDC, ATS, and the U.S. Federal Tuberculosis Task Force and the World Health Organization. His scholarly interests include tuberculosis diagnosis, treatment, and transmission dynamics, evidence-based guidance development, and human subjects research ethics. Please welcome Dr. Philip LoBue.
Thank you very much. I'm going to share my screen. It's a pleasure to be here this afternoon virtually to talk about Mycobacterium bovis disease in humans. And let me preface my talk by saying that a lot of it's going to be about epidemiology because other aspects, particularly diagnostic approaches, is really basically the same as for M. tuberculosis. And there's a slight difference in treatment related to drug resistance, but there's actually fairly limited literature on that, but I will cover those aspects toward the end of the talk. So let's start out by saying, well, what is Mycobacterium bovis, in case you're not familiar with it. So bovis derives from the late Latin bovinus, which means related to a cow, which is derived from the Latin word for cow, which is bos. So clearly this is something related to cattle and Mycobacterium, a type of bacteria. So a Mycobacterium species that's related to cattle. So historically, probably most, if not all of you are familiar with Robert Koch's discovery of Mycobacterium tuberculosis as the bacteria that causes tuberculosis in humans. It turns out that 16 years later, an American, Theobald Smith, noted that there were actually differences between tuberculosis species which were infecting cattle, M. bovis, as compared to those which typically infected humans, M. tuberculosis. In 1901, Koch actually declared that those bovine strains of TB are not dangerous to humans, and there was no reason to worry about eradication in cattle. And although Koch was right about many things, in this case, he was actually quite wrong. Because subsequently, a Scottish veterinarian argued that M. bovis was a cause of disease in humans, particularly abdominal TB in children, as he was able to isolate the organism from a child with meningitis. And shortly thereafter, a British Royal Commission conducted extensive research on this topic, and they were able to show that cow's milk contaminated with Mycobacterium bovis caused extrapulmonary tuberculosis in people, and in particular, children were at increased risk for cervical lymphadenitis if they were consuming cow's milk. And one of the interesting things about M. bovis and something that's changed in recent years is kind of which came first and which evolved from the other. So for many, many years, it was believed that M. tuberculosis evolved from M. bovis. I mean, we are aware of many examples of zoonotic diseases where initially the organism is in an animal and subsequently the organism adapts to humans. However, as people started to look at the genetics of these organisms, it looks like that's not the case. It's actually the opposite. So in particular, beginning with studies of gene deletion analysis, they strongly suggested that actually M.bovis was the final member of a separate lineage, which was represented by a number of Mycobacteria, including M. africanum, and that branched out from the progenitor of M. tuberculosis. So in the next slide, we look at this graphic, which is fairly complicated, but I just want to make a few points. One is, you go back and start with this, which what the authors have labeled as M. prototuberculosis, so the ultimate ancestor of all these organisms in the Mycobacterium tuberculosis complex. It actually is, based on looking at genetics, more closely related to M. tuberculosis because particularly M.bovis and these animal adapted strains have had deletions which occurred, and those deletions have made them actually less related to the original progenitor of tuberculosis. So M. tuberculosis in humans appears to be more closely related to the original progenitor organism as compared to these animal adapted strains, including M.bovis. And so based on that, it really appears that the organism was originally adapted to humans, and it was only later that as it evolved that the organism adapted to animals. And you came up with these animal adapted species, including M.bovis. And in terms of looking at this in terms of a timeline, at least, there's some controversy about how, exactly when this happened and how long ago. But at least these authors think that the original progenitor of tuberculosis probably adapted itself to ancient humans, so before even modern humans. And they're suggesting as long as 2.5 million years ago, which I think might be a bit of a stretch. But there's even some skeletal evidence to suggest that some type of tuberculosis organism could have been in ancient humans as far as 500,000 years ago. And so the M.bovis organism looks like it came about in the evolutionary period, probably 60 to 70,000 years ago. Again, this all points to the fact that probably the organism adapted to humans first, and M.bovis, the animal adapted organism for cattle, came later. And so, in fact, humans gave the infection to cattle. This is just another example showing the timeline in a more linear way. Again, these authors suggesting that as long as 2.5 million years ago, in pre-modern humans, that the organism adapted to humans, and subsequently about 70,000 years ago or so, adapted to cattle in terms of M.bovis. And then these other boxes are just showing various historical finds related to M. tuberculosis, which I'm not really going to talk about, but just to give you the idea of what this timeline could look like. So understanding that everyone finally agreed that this organism was a problem for humans and could infect humans and make them sick, people started looking at ways to combat it. And there were two approaches. One is pasteurization. Pasteurization gets rid of the organism. So in 1908, the US passed their first compulsory pasteurization law. And then in 1917, there was actually the beginnings of a US state and federal bovine TB eradication program, the basis of which is basically testing cattle herds and then culling those who react to skin tests. And prior to pasteurization, it was estimated that it could have been 10 to 30% of human cases, human TB cases could have been due to Mycobacterium bovis, so actually fairly common. So this slide and graphic look at the cattle eradication program over time in the United States for 100 years, from 1917 to 2017. And what it shows, the vertical axis shows the percentage of cattle that were testing positive by skin test. And then the horizontal axis shows how that progressed over time. And as you can see, when the program started in 1917, about 5% of cattle were testing positive. And by 1950 or so, they had gotten that down to 0.46%. And then currently it's pretty much zero. I mean, they do get positive, but those are probably mostly false positives due to how well the test works. We all know, and they also use blood tests like we do interferon gamma release assays, but we know from in humans for M. tuberculosis that those tests are not perfect and give false positives. So when you start getting down to really low prevalence, you can just see basically what you have left are false positives. So pretty much eradicated, but not completely. And the USDA Department of Agriculture has a categorization of states in terms of where they sit in terms of this eradication program. And I'm just going to talk about 2 of those categories because those are the only 2 that exist in the United States right now. The first one is called accredited free status. And these are where you have a herd prevalence of 0 for bovine tuberculosis in cattle and bison. And there's the modified accredited status where it's not 0, but the prevalence has to be less than 0.1% in cattle and bison herds. And this slide shows, this is the most recent one that I could find from USDA, and basically shows the status across the US. And the states in gray are accredited free, which basically means they're 0. And modified accredited is those with a prevalence of less than 0.1%. And what you see is basically the United States is accredited free, except for one little area in the state of Michigan. And I will come back and talk about that a little more later. In terms of susceptible species, obviously cattle are the main one, but there are what are called spillover species, so ones that are not the primary species that the organism affects, but it can spill over and see disease in. And so humans and non-human primates are among those, but there's a whole list of other mammals where you can see M. tuberculosis infection. And to note that these are both domestic and wild. So deer, elk, and other foxes and other wild species in the wild, and then they're domestic like cats and dogs and cattle. So now I'm going to move on and talk a bit about current disease burden epidemiology. So in terms of the most important organisms which cause human tuberculosis, far and away, it is M. tuberculosis. And if we look at the United States and developed countries, about 98 to 99% of cases are due to M. tuberculosis. M.bovis is next on the list, about 1 to 2%, and the others are very rare. Now, there is some substantial geographic variation, in particularly San Diego, where a lot of work has been done looking at the epidemiology, and we're going to talk about that in a little more detail. It's a lot less is known about developing countries. I'll show you what data there are, but because they're just not as systematic about looking for it, it's likely that in some of these countries, there probably is more M.bovis than is known, especially where the organism is enzootic in cattle and pasteurization is not widely used, particularly in some countries in Africa. So when we talk about global estimates, again, it's difficult because there are some individual country studies, but they're often not that systematic, and a lot of times they're only from one location within the country. Nevertheless, there's been attempts to look at that, and particularly I'm going to refer to this systematic review that was published in Emerging Infectious Diseases in 2013, and looked at various parts of the world and to get estimates of the proportion of TB, which was from zoonotic TB, meaning essentially M. bovis. So Starting with the Americas, the median proportion of cases was 0.3%, Europe similar, 0.4, Western Pacific, pretty similar, 0.2. Eastern Mediterranean, there were only 2 studies. They varied somewhat, 0.6% and 2.2%. The one area which stands out is Africa, where the proportion was 2.8%. So that's pretty significantly higher than Americas and Europe, for example. And ultimately, what WHO did was basically looked at these numbers and kind of averaged them out to come up with an estimate of 1.4% of all cases across the globe, which would result in 147,000 cases in 2016 per their numbers. So in North America, again, the disease is relatively rare because of pasteurization and the eradication program in cattle. M.bovis accounts for less than 2% of cases in the US. Again, as I said before, higher in some areas. Mexico appears to be different, though. From the systematic review, the finding was that the median percentage of M.bovis cases was about 7.6%, with quite a wide range. But there were certainly, in 3 independent studies, the proportions were greater than 10% of cases were due to M.bovis in parts of Mexico. There have been reports of fairly high percentage of finding infected cattle in meat processing plants, 17% in one study. And there are parts of Mexico where it's been estimated that up to 30% of the milk is not pasteurized. So clearly it would be a substantial increase in risk in Mexico compared to Canada or the US. In terms of the US, we at CDC looked at this a number of years ago, and we were able to start doing this because of the National Genotyping Program. So we could use genotyping results to distinguish M.bovis from M. tuberculosis, and looked at this over a 10-year period. And what we did was we took the laboratory data where M.bovis was identified by genotyping. We could link it to our surveillance data and then look at the various associated clinical factors and demographic factors. We started with just over 14,000 isolates. We had just under 12,000 where we could link the genotyping and surveillance data. And of those, the vast majority were M. tuberculosis, almost 99%. There were 177 that were M.bovis. We excluded the 10 that were from BCG, likely related to either dissemination from vaccination or treatment for bladder cancer. So that left us with 167 M.bovis TB cases, which was about 1.4%. And among those patients, there were definitely some characteristics that were associated with M.bovis, and particularly almost 90% occurred in people who were Hispanic, 62% were born in Mexico. They tended to be younger, so 19% were under age 15 compared with 2% for M. tuberculosis, and 65% had extrapulmonary disease, which is quite high, and also the percentage of HIV infection among these patients was higher at 26%. This slide's a bit hard to read, and sorry about that, but I just want to make 2 points. So what this table shows is basically M.bovis cases in the US from 2004 through 2019, again, based on using genotyping data to distinguish between MTB and M.bovis. And the 2 points I want to make are that the percentage of cases has been fairly steady. It's usually somewhere between 1.5 and 2%. Over that time period, so similar to the 1.4% we found in the study that we did. And the other is that even compared to overall TB case in the US, there is really a predominance occurring in non-US born persons. So about 80% of the M.bovis cases occurred in people who were born outside the United States. So I mentioned that there clearly is geographic variation in the US. And in particular, I'm going to talk about San Diego. I spent a number of years in San Diego. And this was one of the things when I was working there that was definitely notable about the program, was that we saw more Mycobacterium bovis. And here is a study that was from Tim Rodwell and colleagues in San Diego, again, looking at percentage of cases that were due to M. bovis of all the culture positive cases. And if you look at the box I've highlighted with the blue rectangle, what you see is, in terms of the percentage, which is in parentheses, that it is substantially higher than the 1.4% for the US overall. In fact, it's running more around 10%. So clearly more M. bovis in San Diego. Now, San Diego borders Baja California, Mexico. And I think as you see, that really explains why you see an increased percentage of M. bovis cases there. So when they looked at the characteristics of these cases, they were very similar to what we saw for the US overall. In this table, what we're looking at are odds ratios for various demographic and clinical characteristics. So the first thing is age, and you see that the two younger age groups, so 0 to 4 and 5 to 14, odds ratios 2.4, 4.4 essentially. So clearly higher risk for young people, similar to what we saw nationally. And then you look at race ethnicity. For Hispanic, the odds ratio is almost 8. Extrapulmonary disease, odds ratio of 4.5. And HIV status was borderline statistically significant, but still looked like it was a bit higher, an odds ratio of around 1.75. So again, similar findings to what we saw nationally, just that in San Diego, the percentage of cases due to M. bovis is higher. So another publication from New York City, back in 2004, they had a 15-month-old child die from peritoneal Mycobacterium bovis, so they decided to investigate M. bovis events. And what they did was, again, like we did, looked at the genotyping data, and what they found over a 4-year period was that 35 cases of M. bovis. It was about 1% of all TB cases in New York City, so that is more like the national average, not like San Diego. But again, when they started looking at demographics and clinical characteristics, of the 23 adults, 22 were non-US born from Mexico, Dominican Republic, Guatemala, and Guyana. Of the 12 children, 10 were US born, but they had Mexican parents and predominantly extrapulmonary disease. So now I'm going to talk about transmission. And the one thing which is different from M. tuberculosis is that a major mode of transmission is actually foodborne. As I alluded to early in the talk, it comes from ingestion of contaminated unpasteurized dairy products. So you have cattle that are infected with M. tuberculosis. It gets shed in the milk, and milk is not pasteurized, or the products that you make from the milk are not pasteurized. You have contamination with those organisms, and they can affect people who ingest those products. There is also airborne transmission, which is the same as for M. tuberculosis. And then there is the possibility of direct inoculation through the skin. When this was a common problem in cattle, as the cattle went through slaughterhouses, the people who were involved in that and doing the butcher's work, they could infect themselves, and that was called butcher's wart. And more recently, it's more of an issue for hunters, actually. So this graphic basically talks about the cycle of transmission of M. bovis and what the relative probabilities are in terms of those types of transmissions. So the thickness of the arrow means the thicker arrows mean higher probability of transmission. So the thickest one is cattle to cattle. So that would be the highest probability, is transmission from cattle to cattle. Next, not quite as much, would be cattle to humans, and then lesser probability, the thinnest arrows are either from humans to humans or humans back to cattle. Based on the fact that evolutionary, the organism has adapted itself to cattle. But it turns out it can be a bit more complicated. And it brings me back to the graphic I showed about eradication of M.bovis in cattle in the United States, and the one place where you don't have the accredited free status, which is this area of Michigan. So in Michigan, in 1979, they were declared TB, they were TB free for their cattle. However, between 1995 and 2013, there were 57 cattle herds in Michigan, which were identified as M.bovis infected, and this has continued to be a problem in terms of trying to eradicate that. And so the question is, why? What happened? Well, it actually has to do with the idea of a spillover species or spillover reservoir. In this case, the particular animal, animals are deer. So you may ask, what is the relationship between deer and cattle? We don't tend to think of them so much hanging out together. And it turns out that it looks like there's actually indirect bidirectional transmission between cattle and deer. And so what probably happened was the cattle originally had the infection, but it ended up in the deer population. And initially, it probably wasn't too much of a problem because deer don't generally tend to congregate. But what happens is if deer density increases, and this did happen in Michigan because of hunting restrictions and supplemental feeding, then it actually starts to become a problem in the deer population. And so as the M.bovis prevalence increased in deer, it was transmitted back to cattle. And that mechanism is probably indirect, meaning that it looks like it was contamination of a shared food source. So if a deer is sick, it sheds the organism into hay or whatever both animals might eat, and that's how it's transmitted back to cattle. And this actually was experimentally demonstrated by the U.S. Department of Agriculture, showing that yes, that is possible to transmit it that way indirectly through a shared food source. And so that sets up obviously a more complicated scheme in terms of transmission, because if you bring deer in, you have the other spillover species, and so you could have transmission between cattle and deer, probably largely indirectly. You can have transmission between the cattle, you can have transmission between humans and cattle, humans and humans, and also deer to humans. So a more complicated scheme for transmission and more ways that people could potentially become infected. And so I'm going to talk about a few cases in Michigan that were reported between 2000 and 2017. In fact, Jim Sundstrom, who's one of the authors of this paper, emailed me before the presentation, and I think he's got 2 more cases since then, so I think they're up to 5. And so one of them was a 74-year-old man with pulmonary M.bovis, and he had multiple deer exposures, including running a business with a buck pole, which is apparently where hunters display their killed deer. And that isolate from the patient matched the circulating deer cattle strain in Michigan. There was also a 29-year-old who punctured his finger while he was field dressing a deer and developed a wound infection. So this is the cutaneous, analogous to the butcher's wart. This is in a hunter. And the isolate from the wound and the deer carcass both matched the strain which was circulating in deer in Michigan. And then a 77-year-old with rheumatoid arthritis who was taking low-dose prednisone, also with pulmonary M.bovis disease, and he lived in areas where M.bovis was present in deer, and he regularly hunted and field-dressed deer, so clearly had a risk for exposure to deer. Now, deer are not the only spillover species. In the United Kingdom, they have an issue. In that case, it's due spillover species is actually the European badger. And I'm going to go through an example related to that. So in this example, there were a brother and sister who were living on a farm who were diagnosed with Mycobacterium bovis. The brother had AFB smear negative, but cavitary disease. The sister had AFB smear negative pulmonary disease, but no cavities. Neither drank unpasteurized milk or consumed unpasteurized dairy products. The brother assisted at veterinary examinations and was really close to these cows such that he would become covered in cow mucus and saliva. And the sister had no contact with the cattle. So 6 years prior to the brother and sister getting M.bovis, their cattle, 5 of the 15 of their cattle had M.bovis when they were tested, and that herd was actually slaughtered. They trapped badgers at the time, and 4 of the 5 that they trapped had M.bovis. So it looked like badgers were infecting their cattle, and so they had that cattle herd was slaughtered. They brought in a new herd, which was clean and not infected. However, 3 years later, they found that 3 of their 8 cattle had M.bovis, and they had to slaughter that herd, and then they were able to trap 1 badger and had M.bovis. So even after they had gotten rid of the cattle, which were initially infected, when they brought the new herd in, that's the spillover species, the badgers just reinfected the new herd that they brought in. So in this case, what appears to have happened is that the badgers, similar to what happens with deer, were infecting the cattle, probably through indirect ingestion. The brother, who spent a lot of time around the cattle, probably was infected through the airborne route because he didn't consume any unpasteurized dairy products. And then the brother infected the sister, again, through the airborne route, as we see with M. tuberculosis. So there's always been some controversy about the degree of transmission, particularly human-to-human transmission. And in this quote from 2001, the author says, possibly as a consequence of the assumption that M.bovis is less virulent than M. tuberculosis for humans, there has been a widespread assumption that human-to-human transmission of M.bovis leading to disease occurs rarely or not at all. I think the examples I've already showed are, the example I already showed is that not at all is not correct. It happens. I'm going to give you some more examples. It's probably not as common as for M. tuberculosis. There probably is less virulence for humans, but I think there's pretty good evidence, as I'll go through some more examples, that yes, there is transmission from human to human. So one thing is that in some European countries, there were some MDR, multi-drug resistant M.bovis outbreaks in HIV-infected patients with matching genotypes, which didn't, where some of the people who were infected did not have any evidence of animal exposure or unpasteurized dairy product consumption. So really, it seemed that the only way that they were getting it was through exposure to other humans. And again, case reports of contacts of patients with pulmonary M.bovis who became infected and really had no other source. So when I was in San Diego, we looked at a couple of other things. One is the characteristics of M.bovis patients. Now, M.bovis patients are more likely to just have extrapulmonary disease. So those patients who just have extrapulmonary disease, they're not likely to transmit. However, for the patients with pulmonary disease, when we looked at them, the characteristics in terms of infectiousness were similar. So if patients with M.bovis and M. tuberculosis with pulmonary disease in San Diego, when we looked at this, they had similar rates of cavities and similar rates of positive AFB smears, which suggests the possibility of transmission. And then we also looked at tuberculin skin test conversion rates among contacts, comparing contacts of patients with pulmonary M.bovis to contacts of patients with pulmonary M. tuberculosis, and the rate of skin test conversions were similar in the 2 groups. And finally, we also had our own cluster of 3 pulmonary M.bovis patients in one family, and they denied consumption of unpasteurized dairy products. Now, you can never be 100% sure that something wasn't missed, but at least in this case, there was certainly they all had pulmonary disease, so there was certainly reason to think that person-to-person transmission could have occurred in that family. And here's another interesting example from the United Kingdom. So this was a cluster of 6 cases of M.bovis. And among these 6 patients, what they found was that there were 2 who really had no known animal exposure or any contact with unpasteurized milk. There was one, patient number 1 in the table who did. And then patients 2, 5, and 6 maybe, but not really strong risks um, for animal exposure. They had some limited cattle contact or childhood farm visits, so not especially strong. Can't rule it out, but there were certainly 2 patients who they could find no evidence that they were ingesting unpasteurized milk or had a lot of exposure to animals. But what they did find was that these people were in contact with each other. And so look at this diagram in the dark red circle, patients 2 and 3 were partners living together. And then the other patients, 1, 4, 5, and 6, had contacts either through, in one case, patient number 4 was a friend of the other 2, or they had contact at a known location. So it turned out to be one case, a local bar with extensive social contact. In another case, they were all hanging out at the same nightclub. So it suggests that at least probably a couple of those patients were infected through person-to-person transmission. Now, the bigger, the more common risk factor appears to be foodborne transmission. And in particular, probably imported cheese and queso fresco, which is unpasteurized. So it's a fresh cheese, particularly made in Mexico, often from unpasteurized milk. This is not commercially available in the US, generally imported by individuals for their own consumption. And so it bypasses the usual FDA and USDA regulation and inspection. So what is the evidence for implicating Mexican cheese in this foodborne transmission? I'm going to go through a number of examples here again, starting with San Diego, which borders Baja California, Mexico. I think to say the most studied because of the higher prevalence. And they've actually done a study where they compared strains of M.bovis in humans compared to the cattle strains from Mexico. The FDA and USDA have actually done some sampling of some of these products that are imported across the border. And then there's also some circumstantial evidence based on some clusters of cases in New York City and Maryland. So starting with San Diego, the first thing is that you actually see a pretty high, among the extrapulmonary disease, a pretty high prevalence of gastrointestinal disease. So gastrointestinal TB is 9 times more likely with M.bovis. And the patients tended to either be from Mexico or US born Hispanic with parents from Mexico. Looking at the children, interestingly, so infants did have M.bovis with 6% of culture positive cases, but children, older children, it was 35%. Actually greater than 35% of cases. And so what's the difference? Well, infants, right, they're either usually getting breast milk or formula, they're not eating cheese. But as the child ages, then they do get into age group where they probably are eating cheese. And so that would explain why you see such a higher percentage in the children who are not infants. We know that there's been a problem with disease in Mexican cattle herds, and then at least in the past, up to 30% of the milk was not pasteurized in some parts of Mexico. So there was definitely risk there. And then another study done in San Diego looked at skin test results in children, and children who consumed raw milk or cheese were 3 times more likely to have a positive tuberculin skin test. So the FDA and USDA actually sampled products coming across the border, particularly cheese products, and it wasn't actually primarily done for M.bovis. There are other concerns, including listeria and other infections. But it turns out that in one of the samples that they collected through this process, they actually were able to isolate M.bovis from one of the samples that that people were bringing across the border. So it, which I think, you know, is pretty interesting, is because it's really kind of like looking for a needle in a haystack. And the fact that they were able to, just through this random sampling program, actually able to isolate it from one of the samples really raises questions about what the likely prevalence could be among these, among this imported cheese. And then another study among Latino adolescents done in San Diego in a survey found that 1/3 of them indicated that they ate queso fresco. So the consumption of this product was fairly common in San Diego among Latino adolescents. And then finally, comparison of strains of M.bovis from humans and cattle. So in this study, they had 106 human isolates of M.bovis from San Diego, and then they had 496 isolates from cattle. This was just a convenience sample from a surveillance program, and it turns out that 91% of the human isolates had an identical spoligotype, the one found in Mexican cattle. So again, it's strongly suggestive of what the source of M.bovis is in most of these cases in San Diego. So in New York City, I mentioned that they had done the investigation based initially on the child who died. They were able to interview 23 of the 35 patients, and 19 of the 23 reported eating cheese imported from Mexico. They were either got that cheese either from a courier agency, which brought it from Mexico. Sometimes visitors, friends, family brought it in their luggage. There were some Mexican specialty groceries that apparently got this cheese. And then there were even door-to-door vendors that people got this, that they were able to get this cheese. And Maryland had 5 pediatric cases of M.bovis. Again, they had one death. And all 5 of those cases involved Mexican-American children who were born in the US. And in all 5 cases, the children consumed Mexican cheese or cream products that were believed to be unpasteurized. So I've gone through the epidemiology, a lot about transmission, various ways that people can be exposed. And now I'm going to talk about clinical and radiographic manifestations. And there's not really a lot to say because basically it's indistinguishable from disease caused by M. tuberculosis. So you just cannot tell by a person's symptoms, their chest x-ray, their physical exam. Now, the demographic, clinical, and social characteristics may be suggestive based on what I told you, but even there, you're not gonna be able to distinguish. It may suggest it's more likely. And what are those things? Well, if it's a person who's younger age, it's extrapulmonary disease. If they were born in or traveled to Mexico, especially if they have a history of consuming dairy products from Mexico, that would suggest it could be M.bovis. But ultimately, the only way you're going to tell is by differentiation in the laboratory when you get an isolate and identify it. So fortunately, now we have the modern genetic methods, but it used to be biochemical testing that was required to figure this out. So one thing is, if you use solid egg-based media, M.bovis requires pyruvate supplementation or it won't grow. It is basically universally resistant to pyrazinamide. So if you have monopyrazinamide resistance, that's something that's suggested, but you can have monopyrazinamide resistance with M. tuberculosis, so it's not absolute, but certainly in a patient who has, all the demographic and clinical suggestive features, that would really set you thinking this could be M.bovis. Older tests, TCH sensitivity, niacin test negative, nitrate test negative. I don't think anyone does these tests anymore. But now we do the genetic techniques. So genotyping, which is what we used in that study that we published, the study from 1995 to 2005. We used that combination of spoligotyping and Myriu, gene deletion analysis, and I showed you as the organism evolved that M.bovis lost genes, so that distinguishes it. But now we have whole genome sequencing, which basically we're getting in just about every isolate in the US, so that can be used to tell the difference between M. tuberculosis and M.bovis. So in terms of treatment, the key thing that I mentioned was you have basically universal resistance to pyrazinamide. So for that reason, the standard treatment we know for susceptible M. tuberculosis would be isoniazid, rifampin, and pyrazinamide for 2 months, and then isoniazid and rifampin for 4 months. But for M.bovis, it's pyrazinamide resistant, so the standard is generally isoniazid and rifampin, at least for 9 months. And some clinicians will add ethambutol. But typically in San Diego, we would not add ethambutol once we knew the susceptibilities. If we were susceptible to isoniazid and rifampin, we would just use those drugs. There's been one systematic review of treatment that I could find. There's just not a lot of literature on the treatment of Mycobacterium bovis, and this included three observational studies. So again, we're limited to observational studies. There are no randomized controlled trials that I'm aware of. And what they did was they grouped into 2 cohorts of 156 patients who received isoniazid and rifampin for 6 to 9 months, and then they had 2 cohorts of 113 patients who received isoniazid, rifampin, and ethambutol for 6 to 12 months. So when you include all poor outcomes in the denominator, including death, the success rates were 74% for the isoniazid rifampin regimen, 79% for the isoniazid rifampin ethambutol regimen. It looks like maybe the 3-drug regimen's a little better, but the numbers involved don't make that statistically significant. And so you really can't conclude much from that. Similarly, when you take out death from the denominator and only look at success plus failure plus relapse, the rates were actually higher in the isoniazid rifampin regimen than they were in the 3-drug regimen. But again, they were quite good. But again, because of the small numbers, you can't really draw a definitive conclusion. And it's actually opposite of what was in the analysis, which excluded deaths. So it's really hard to say that there's any difference between using 2 or 3 drugs. Now, what the difference the key thing in the difference in these 2 analyses is about death, and the problem being that there was a fairly high mortality in a number of these studies in the patients with M.bovis, and probably related to a high percentage of persons with HIV, and these studies being done at times before highly active antiretroviral therapy was available. So what the authors concluded was that basically, because of the small numbers, they couldn't conclude that there was an effect of ethambutol or not, and whether you used a longer duration or not made a difference. So we're kind of back, to where we were. Isoniazid and rifampin definitely for, I would use 9 months, but some people have used shorter. And then whether you add ethambutol or not, if it's beneficial, no one really knows. But if you think it's important, you certainly can add it. I don't think there's much risk to doing that. And then again, as I mentioned, the major reason for the low success rates when looking at all outcomes had to do with high mortality. And in at least 2 of those studies, there were very high rates of HIV co-infection, and some of those in some of those patients, it predated antiretroviral therapy. So those patients clearly would be at higher risk to die. So this is one of the studies that was included in that systematic analysis when we looked at data from San Diego. And so the green bars are tuberculosis, and the kind of maroon bars are Mycobacterium bovis. And when you look at this and the various outcomes, you can see that successful completion was fairly similar, maybe slightly less in the M.bovis, but it was not statistically significant. But if you notice where the difference appears to occur, again, it is among deaths. And the issue of having I think a fairly high percentage of persons with HIV infection. You see, this goes back to 1994. So some of those patients were treated before highly effective antiretroviral therapy. Could explain why that happened. It was the higher percentage of patients with, again, HIV infection, not necessarily that M.bovis has a higher mortality. And finally, latent TB infection, there really are no data. But in theory, the recommended M tuberculosis regimens for latent TB should work if the person is infected with a strain that's INH and rifampin susceptible. So if it's a contact and you know the person who they were exposed to and you know their what the susceptibilities are, as long as they're susceptible to INH and rifamycin, you can use one of the recommended regimens. And then if not, you have to base it on you know what you think the susceptibilities are from the likely exposure in terms of latent TB infection. Okay, so that concludes my presentation, and I thank you very much for your attention. I think we are now open for questions.
Yeah, so there's a few questions in the question spot. So the first one is, will IGRA test be positive in M.bovis infection in humans, and parentheses, and cattle?
Yes, so they are positive that there's nothing. In fact, you know, the advantage of IGRA, it turns out that there's a difference between, in terms of IGRA tests, there's a difference between the pathogenic M.bovis that people get sick with and BCG vaccine. So in terms of the reaction of IgRA tests, so even though IgRA tests are generally going to be negative because of BCG vaccination, they will be positive for people with pathogenic Mycobacterium bovis that makes them sick.
Okay, next question. Can you explain how we would know the difference between M.bovis and M.bovis BCG?
I think, I guess if you're talking about in a patient, there, well, two ways I think you would know. One is generally is, you know, if there's somebody who had no other risk factor, then they got, for example, bladder cancer therapy for BCG, I think you would pretty much know that that's the case. Now it's harder in someone who's had a BCG vaccination because they also could come from a place, let's say from Mexico, where they're at risk for both. So there, if the person's sick and you can isolate the organism, genetic testing that we have now available can differentiate between the two. So that's basically how you would have to do it. If you didn't have an isolate, it could be difficult.
Okay, next question. Are M.bovis infection rates in young children lower in Mexico, where they vaccinate with BCG, compared to non-vaccinated Latinx children in U.S. who may have similar exposures to unpasteurized dairy products?
I do not know. I don't know. I don't even know whether that's been studied or not. I haven't seen the literature on it, but I don't know. I haven't seen anything, so I think I don't know the answer to that question.
The next question: what's treatment recommendation for bovis for RIF intolerant?
Right. So if they can't have rifampin, then the options are would be isoniazid, probably isoniazid, ethambutol, and a fluoroquinolone. Duration is a good question. I think probably certainly at least 12 months, maybe longer. But I think when you have a situation like that, you really need to talk to an expert, and it's going to depend on how well the person responds. But assuming that they're susceptible to isoniazid and ethambutol and a fluoroquinolone, those would be the first 3 drugs.
Okay, let's see this one. I'm not sure if clients with M.bovis are DOT'd. I wonder if not. Then wondering if some of the deaths may be possible due to poor adherence.
So I don't, that probably varies from program to program. I would say in San Diego, that was not a criterion that we used for DOT. So there was no reason to think that in the San Diego data anyway, that would be different. But I can't say that's not true other places, that they might not use DOT for M.bovis. So it's possible. But I think the HIV was probably the bigger issue Now the other, I shouldn't say that's the only issue, right? So I focused on that, but the other thing is you have to remember that if you're dealing with children and extrapulmonary disease, there are other things that could increase mortality, like meningitis. So if you're seeing more meningitis among your M.bovis patients because they're kids who are getting meningitis, then that could increase mortality too. So there are other things.
Okay, let's see the next question. In the case of the siblings from the UK, I thought the brother had non-pulmonary disease. How is it speculated that he could have infected the sister through a respiratory route?
No, he had pulmonary disease, which was actually cavitary, I believe.
Okay, let's see. Any comments on human extrapulmonary disease involving the urinary system? Mainly interested in potential for risk of transmission to cattle.
So theoretically possible, right? Because of studies which have shown indirect transmission. If there was a person with M.bovis had urinary disease and they were urinating on areas where the cattle fed, it's theoretically possible, but I don't know of any real documentation where that's been shown to occur. Certainly, you have extrapulmonary disease is more common. The GU tract is not one of the more common ones for M.bovis. I mean, it's, lymph nodes tend to be the most common, and then you do see a surprising amount of gastrointestinal disease. Not surprising considering how people get it, but certainly a lot higher than for M. tuberculosis. But even that is not, because GI M. tuberculosis is so low. It's still not one of the higher ones. It tends to be more cervical lymphadenitis, and so it's a possible, but I'm not aware of any clearly documented cases of that occurring.
Okay, and I missed this question earlier. Why do the local health departments in the United States treat MTB but not M.bovis?
I don't know. I can't speak for all health departments. The ones that I've interacted with, certainly in San Diego, we treated a lot of M.bovis. It was about 10% of the cases, and New York City, for example, clearly they were treating those cases. So I don't know if there are health departments that aren't doing it, but given that I think there's evidence for human-to-human transmission, it is a public health issue. And so I don't know why they would not do that.
Okay, this next question. The desired goal is to not have disease. How do we protect our dairy and beef herds from being infected from humans with M.bovis? Many of our workers come from Mexico and possibly infected. How do we get public health involved to help farmers with testing of workers for Mycobacterium, bovis, and M. tuberculosis?
So, I mean, again, I don't know, what the exact risk and incidence if this occurs. I don't know. I mean, it's not been documented, so it's hard for me to answer. It's really a hypothetical question. The recommendations for people who are at risk for any form of tuberculosis, we recommend that those people be screened and that they get testing for latent tuberculosis infection. And if they're positive, they get treated for that. And then during that testing process, one of the things you have to do is exclude tuberculosis disease. So if primary care providers were involved in doing that, as recommended by the U.S. Preventive Services Task Force, that's one way we can get people screened and prevent them from potentially spreading it. The second way is if you're in an occupation where it's a major concern, then you could consider having an occupational testing program, but that would be up to the institution or group to decide to go ahead and implement such a program.
Okay, let's see this next one. The Sanford Guide states isolation not required for M. bovis disease. Is this correct?
I would say it is not correct. I mean, I think based on the number of examples that I presented and information from San Diego about contacts of persons with pulmonary M.bovis, that they should have the same isolation requirements as people who have pulmonary M tuberculosis. Now, it could very well be that, if and I don't think there's any easy way to study this, but quantitatively, maybe it's a lower risk, but it's not zero, and it clearly occurs. And it's probably it's close enough that I think you need to do the same thing, and isolation should be part of what the public health department does for persons with pulmonary M.bovis.
Okay. So this next question, what is in the future as far as further studies regarding M.bovis?
Yeah, I don't know. I mean, it's not an hot area of research because it's not, as far as tuberculosis goes, it's not that common. So, right now I'm not aware of any major studies, particularly looking at M.bovis.
Let's see. Are guidelines for identifying contacts for those diagnosed with M.bovis the same as the guidelines for those diagnosed with pulmonary TB?
Yes, they should be treated the same way.
Let's see. Why? Can cattle not be treated, and why do they have to be slaughtered?
So I'm not a veterinarian. Let me say that to start with. But I do know where we have dealt with this in other animal species. It's just really difficult to impossible. So I know one example where we've had to consult in cases is elephants, for example, because elephants, in this case, it's not M.bovis, but elephants get M tuberculosis, and those are animals that are potentially endangered, and really every effort trying to save them and not get sick, but it is extremely difficult. And I just think that it's just from a practical standpoint, getting the correct dosage and everything, and for a long period of time, that it's just not a feasible thing to do.
Okay, I think those are all the questions. If there are not any further questions, thank you so much, Dr. LoBue, for your time and that great presentation.
Well, thank you.